Thank you, Chair, for your kind introduction. And I would like to thank the organizing committee for inviting me to speak and to participate in this wonderful session. Today, my talk will be focused on how we make the best use of the tools what we all familiar with to facilitate hepatitis B elimination. And this is my disclosure. I will give a short overview of the epidemiology of hepatitis B and HIV in the region. And next, I will discuss the hepatitis B vaccination, how the guidelines and the data says about it, and some issues beyond. Next, I will talk about the new NRTI on HIV prevention through the Treaters Prevention Program or pre-exposure prophylaxis. So let's start it from the global disease burden. The hepatitis B has caused a great deal of impact in the global, and it includes 325 million of people infected with hepatitis and 800,000 of mortalities annually. Only 10% of people chronically infected with hepatitis B knew their status. So, since the neonatal vaccination has changed the landscape of hepatitis B, we expected the prevalence will change from this kind of graph to this graph. That in this graph, in 2019, children aged under 5, the prevalence of hepatitis B surface antigen decreased to less than 1% in a lot of countries, shown in the blue one or green ones in this map. So we are hoping a new future heading like this to become the general population's prevalence. So in the long-term follow-up data in Taiwan, we noticed that the effect of neonatal vaccination actually sustained till the early adulthood. I know this graph looks very busy, but let me draw your attention to the dashed line labeled with 2019. It stands for that in this year of 2019, all the people aged under 31 years old has a prevalence rate lower than 2%. And this is precisely the first birth cohort born in the first year of neonatal vaccination program implemented in Taiwan in the year of 1986. So, expert has proposed this strategy for hepatitis B eliminations. First, we should start from screening for the pregnant woman, then deliver the perinatal transmission prevention for the children, and complete the first dose, followed by 2 subsequent doses of the hepatitis B vaccination in 6 months of birth, and providing the post-vaccination monitoring for high-risk populations in these groups. And finally, when a person got infected with the hepatitis B, we should manage and treat them properly, and especially when they were entering their sexually active reproductive age. Surveys have reported acute hepatitis B infection in some populations, with an average incidence of 1 per 100,000 person-years of follow-up in general populations. And the report comes from US, Taiwan, and Republic of Korea. Still, these patients were most concentrated in some subgroups, such as MSM, people who injecting drugs, or people who have multiple sex partners. So, we're already aware of the syndemic of the HIV and HBV because of the shared transmission routes, and the co-infection of this disease actually put a mutual detrimental effect on both disease. So in this study, we can see the mortality were higher for co-infections with HIV or HBV, or HIV, HBV, and HCV triple infections in here, this graph. When we provide healthcare services for our patients living with HIV, they will definitely receive some screening for hepatitis B and C while they're entering for the treatment. However, the subsequent follow-up testing is inadequate. Half of them did not receive any follow-up testing when they after they entering the healthcare systems annually. So we can see the second part of the bar is really short. And while people who reported having some risky behaviors, seldom of the doctors will provide testing for them afterwards. And also, while women who plan pregnancy or who are pregnant, the testing percentage is not 100%. So that's a shame. The testing for hepatitis was actually inadequate for people living with HIV. To prevent our patients from contracting hepatitis B, we will naturally offer them the hepatitis B vaccination. But for people living with HIV, the vaccine response is actually lower, with the response rate average about 65% to 88%. So in the guideline and previous data says that we should offer them higher doses of vaccination with probably 3 series doses or 4 series double doses vaccination. And the response rate could reach up to 85 to 95%. This was pretty good. And there is new adjuvant toll-like receptor 9 agonist hepatitis B vaccine. And this study is conducted in the hepatitis B naive people living with HIV with a 3-dose schedule. And we should know that in this study, the CD4 count, the median CD4 count is actually quite high, with 625 counts in this study. And the dose schedule is actually 1 dose more compared to the schedule designed dose is 2-dose regimen for the toll-like receptor agonist vaccine. So this is a super intensive regimen in this study. So the result is excellent with 100% of response in this study. And there are 88% of people respond well with the antibody titer higher than 1,000. This indicates the very strong protection and also hint and durability in this response. So this table summarizes the guidelines says about the hepatitis B. The DHS guideline and ESCS guideline both recommend double dose series and toll-like receptor agonist vaccination for the primary vaccination and for the second series for the non-responders. But for the WHO, because their position on hepatitis B were based on the position paper written in 2017, so they did not discuss much on the double dose regimen or the toll-like receptor agonist vaccines. As for the timing for booster, down here, all the guidelines suggest the antibody titer lower than 10 to have a booster vaccination. But for British guideline here on the right-hand side corner, they say that the antibody titer could be boosted while they are lower than 100. They will be safer. What haven't been discussed is that when the global coverage rate of neonatal vaccination is increasing, so more and more people grow up under the neonatal vaccination policy. So what we don't know is that whether a higher doses still do better for people living with HIV who had received the neonatal vaccination when they were young. The literature and evidence has discussed about the people on the upper side of the diagrams that they do not receive any hepatitis vaccination prior to their HIV acquisition. So while they are entering their HIV services, they are receiving their first vaccination in their lives. However, for the people who have received the neonatal vaccination, they have the vaccine taken before their HIV acquisition. Will this difference make our judgment different? So we are curious about these issues. That's why we are going to do this study. My colleague and I conducted a randomized control trial in multi-centers in Taiwan. The participants will naturally include the people who were born after the universal vaccination program. And this intervention were the standard or double doses of hepatitis vaccination delivery at 0, 1, and 6 months of the time. So this is the result. They both did very well at week 28 with a response rate at 91 over 98%. However, for the double dose group, the results still better than standard dose at week 48. As for the high titer response, defined as the antibody titer higher than 100, the double dose did better than standard dose at both week 28 and week 48. So let's move on to the next part of the antiretroviral therapy on the hepatitis B prevention. Actually, the concept of the treat as prevention started from the MTCT. And nowadays, WHO even raised a campaign of triple elimination in hepatitis B, HIV, and syphilis. For the treat as prevention in hepatitis B MTCT, the data started to accumulate in the previous decade, and basically it was summarized in this meta-analysis with a poor protective effect regardless of the choice of antiretroviral treatment. The tenofovir, lamivudine, and tavivudine were both effective in preventing the mother-to-child transmission of hepatitis B. And the maternity and or the infancy safety were excellent. So this study actually supports the WHO recommendation in 2020 that the pregnant woman with a positive surface antibody with high hepatitis B DNA load or a positive E antigen should receive the tenofovir prophylaxis from the gestational age of 28 weeks until at least the birth. Oh, okay. So, as the HIV clinician, we are aware of the dual active antiretroviral therapy, namely lamivudine and tricycline and tenofovir to prevent both HIV and HBV. And in the previous several observational studies, we noticed that in people living with HIV who are taking the antiretroviral treatment, if their antiretroviral treatment containing some element who have which dual active against HIV or HBV, HIV and HBV, the incidence of hepatitis B will reduce. And actually, for the one who are taking the tenofovir regimen, the effect is actually more robust compared to lamivudine monotherapy. So when we prescribe a dual active antiretroviral treatment, we are actually expecting them, if they are taking them regularly with great adherence, this can protect them from HBV exposure events and to prevent acute HBV infections. The ESS guideline even suggests that in case of non-responder of hepatitis B vaccinations, ART should contain the tenofovir or TAF. We will naturally imagine that if the at-risk population were put on pre-exposure prophylaxis containing the tenofovir, well, either with event-driven or daily PrEP. Does this kind of effect still exist in this population? We don't really know. So, in this newly published nice articles done by Japanese groups, they conducted a prospective cohort study in MSM. They test the bacteria, STIs, and hepatitis B seromarkers prospectively every 3 months for the PrEP users. And in this study, they allowed both daily PrEP and event-driven PrEP to test for the instance of hepatitis B, bacteria, STI, and HIV in these subgroups. So we have this kind of 3 groups in these studies. Then this nicely designed and this beautiful Kaplan-Meier curve show that a huge difference between the PrEP non-user and the user of the daily PrEP or event-driven PrEP. we can clearly see that the blue lines indicate the PrEP non-users, and the incidence rate of hepatitis B were actually quite high, with 33% cases in among 1,000 patient years of follow-up. And for the daily or event-driven PrEP, the incidence was really low. And there is even zero infections among event-driven PrEP users. And there is only one case in the daily PrEP groups. And later in this study, they actually mentioned that the patient reported non-adherence to the PrEP dosing during the study. So we can conclude that the effect of PrEP in preventing hepatitis B is excellent. And another interesting part of this study is that they even look into the effect of hepatitis B vaccination. They look at the PrEP non-user and find out some people who had an antibody baseline titers to be protective at the baseline, and they look at their instance. The result will be 17 cases per 1,000 patient year of follow-up. So this study nicely illustrates the effect of PrEP and the hepatitis B vaccination. Okay, so nowadays we have several modalities for pre-exposure prophylaxis, including tenofovir-containing regimen such as TAF and TDF. It has many real-world data and experience and easier for administration, but it also required persistence and adherence. While we are welcoming the long-acting cabotegravir to join the pre-exposure prophylaxis, they are excellent efficiency in clinical trials, but we were facing some probable barriers, including intensive interactions with systemic or health delivery, great expense, and difficult in decentralization. And we should always consider hepatitis B vaccination along with these services. While we are providing the services of hepatitis B, we should always provide hepatitis B vaccination to these clients. And the IPREGRADE study actually were an excellent example in this, because they provide 79% of the patient to have at least one dose of hepatitis B, and 75 of them received a complete series. Okay, so this is my summary. To make the best use of our tools, including vaccines and antiretroviral agents, we should regularly screen for our patients with the hepatitis and provide timely vaccination if they were susceptible. We can provide double dose or toll-like receptor agonist hepatitis B vaccine to provide a better immunogenicity. And we should consider additive benefit of tenofovir-based prophylaxis in preventing hepatitis B. So finally, I would like to say that we should target a risk population, not diseases. We should do the program and services integration on PrEP or viral hepatitis B and STDs. We should consider every PrEP visit as a major opportunity to propose and complete HBV vaccination. And thank you. This is my talk. Thank you.